Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello again from Axxess headquarters. This is Jennifer Gibson, a registered nurse and senior clinical consultant here at Axxess, and we are going to be working with you today on an Oasis D accuracy webinar series. This will be a 4-part series in which you'll learn about Oasis D changes, why Oasis is important, and then you'll get some item-specific guidance regarding the new items, the GG items, and J items. Today's webinar is part 1 of a 4-part series, and we'll go ahead and get started today. Please note that the slides that you will have access to are just meant to be cue points. And when you have these later and you're referring back to them, please bear in mind that not everything I'm telling you today is going to be on these handouts, and that, of course, with any CMS regulation, it changes from time to time. So at the time of recording, this is accurate. There may be updates if you're downloading this in the future. So just be careful about interpreting guidelines and requirements based solely on the slides if you should keep these and print them out, okay? What are our webinar series objectives? Well, we're going to be verbalizing understanding of the purpose of Oasis D. We are going to understand the official Oasis D guidelines and conventions. We're going to learn the new and modified Oasis D items. We're going to understand Oasis D implications in quality, payment, and outcomes measurement. We're going to learn clinical tips for obtaining accurate Oasis D data, and then we'll see some item-specific guidelines that we're going to apply to scenarios to give us enhanced learning opportunities. Today's series, we're going to talk about an overview, basically, of the Oasis and why it's important and what we're trying to accomplish with the Oasis. Now, as with any of the regulation that's been coming out from CMS in the past few weeks and months and years, we notice that there are some specific goals and themes that run through all of the different guidelines and changes that are going on. And really, it boils down to patient-centered care, and that's kind of what I like to reference, the dot in the triangle that you see here on the screen. The patient is at the center of these changes, and really they all tie into the triple aim for healthcare, which is to improve the health of the population that we serve, to increase the experience of care and do quality care for our patients or beneficiaries, as they're referred to by CMS, as well as the caregivers. And then do all of that while we're really looking at and managing per capita cost per beneficiary. So we want quality care in a cost-effective way for our patients. The importance of Oasis D. Why is that so important? Well, first of all, Oasis accuracy is paramount for many reasons, and we're going to talk about that in just a moment. But if your Oasis is not accurate, we can see that that's now tied to the conditions of participation. It's going to affect our data that we use for QAPI and so on. CMS is actually using data to make informed decisions these days, and the Oasis is part of the data in which they use to make those decisions. Now, because of the Impact Act of 2014, post-acute care standardization of quality measures result in ongoing measures being changed in the Oasis. And that's why we've seen so many updates to the Oasis data set in the past few years. And that's really what's going to change in January of 2019 with the Oasis D. We're seeing additional GG and J items added to our Oasis. Now, the Oasis data are used for the following reasons. Among others, CMS rulemaking, as we've already talked about. We know that CMS looks at our Oasis data. They do a lot of data mining nationwide and look at all kinds of different things and use that to make decisions. They also, of course, use the Oasis for payment. With Home Health PPS, or Home Health Prospective Payment System, we get our clinical, functional, and service utilization domains ranked by what we answer in our Oasis items. And then, of course, agency quality monitoring. The agency itself is able to look at your own Oasis D data in the way of CASPER reports to look at everything from benchmarking, your average patient age, to your primary diagnosis and all the way to your outcomes and so on. And then, of course, the Oasis is used for state survey activities. So gone are the days when you could hide charts and all that fun stuff when the surveyor was due. Now, because of Oasis and having to export those into the database for CMS, the state surveyor is privy to that information through different reports like the CASPER reports, and they already have a good idea of what's going on in your agency before they arrive. They can then zero in on specific things they want to review and look at whenever they come into the office because of the Oasis data. So we know from just those 4 or 5 points that the Oasis is very important for many reasons, and accuracy is even more important. So let's talk a little bit about what the Oasis is. And I'd like to give this brief review because oftentimes as clinicians who are trained professionally, sometimes we don't fully understand the Oasis, especially having come from a different setting. The Oasis itself is an acronym that stands for Outcome and Assessment Information Set. And that's really important to understand because the Oasis is geared toward being able to monitor outcomes for the patient. It's not what we would consider a professional head-to-toe assessment, but rather it's a set of questions that have been designed to help us look at outcomes for our patients and quality. So the Department of Health and Human Services was required by law back in the early 1990s to monitor the quality of home health using a standardized, reproducible assessment instrument. And in 1999, the use of this Oasis instrument became a condition of participation for Medicare and Medicaid home health. All the elements in the Oasis were developed, tested, and refined over 2 decades by CMS as well as the Robert Wood Johnson Foundation and the New York State Department of Health. The Oasis instrument allows systemic comparative measurement of patient outcomes at 2 points of time, and we refer to that as a quality episode. Now, often as clinicians in home health, when we think about an episode, we think about a payment episode, the from and to date at the top of our care plan. But that's different than a quality episode. A quality episode is that time point so that we can see what happened at the beginning and what happened at the end. And the beginning of a quality episode is either a start of care or a resumption of care, whichever is the most recent. And then it ends with either the transfer or the discharge of the patient. So, for example, you might have 2 quality episodes within one 60-day payment episode. If, for example, the patient's admitted and they're transferred to the hospital on day 15, on day 25 they're resumed or have a resumption of care, and then you discharge them on the 60th day, you would actually have 2 start and stop periods within that 60-day payment period. And so those stop and start periods or beginning and end points, those are your quality episodes. And that's really important to know as we go forward because of the different items and what you're supposed to ask and when you're supposed to review with the timelines that we're going to get into in part 2 of the series. But anyway, outcome measures, which is what we're striving for with the Oasis. The outcome measures are the basis for outcome-based quality improvement, or OBQI, efforts that the home health agencies can employ to assess and improve the quality of care that they provide to patients. So by looking at your quality and your outcomes and looking for trends when things are not doing that great or figuring out why things are going really well when they are, what processes you have in place, that can help you with your OBQI efforts. CMS provides data reports regarding process quality, risk-adjusted outcomes, and potentially avoidable events. Again, those are held in your CASPER reports, and those reports are accessed in the same portal in which you go in and you export your Oasis. That's through the CASPER report system. Now, the goals of the Oasis are the following. These items in the Oasis are designed to be discipline neutral. They assess the patient's care over the course of treatment. They measure the patient's quality of care. They define the patient's outcomes. They provide that OBQI data as we talked about. And CMS can even identify fraud and abuse using the Oasis data. Agencies can access their patient-related characteristic reports and patient tally reports through the CASPER reporting system that we just talked about. But we also know that our Oasis is published on Home Health Compare and our 5-star reports. Now, as far as patient-related characteristic reports, these are really important pieces of information to know, Because, for example, if you're looking at PEPR reports, which are not in the Casper, it's a separate report. PEPR reports talk about utilization, for example. How many episodes do you keep your patients on home care for an average? Or what is your usual episode payment rate? Or what is your therapy utilization, and so on. So if you have outliers when you're looking at your PEPR reports, maybe your payments are $5,000-$6,000 and the national average is $3,000. Or you average keeping a patient on services for 4 recert periods or cert periods, and the national average is 1.5 to 2. When you dig into your Casper patient-related characteristic reports, you may or may not be able to find reasons as to why your length of stay is longer. For example, if the national patient average age is 73 years old, and you go in and look at your average patient's age and it's 83 years old, then that 10 years, that could be a key or a flag to help you understand your patients may be older, have more comorbid conditions, so on and so forth. So all of that with your patient-related characteristic reports can help you to look at your data and come up with some kind of plan to analyze and see what's going on in your agency and monitor that further. All right, so let's look at the Oasis changes here. In Oasis D, what's new? Well, first of all, the Oasis items changed in order to reduce data collection burden, to implement those Impact Act items that we will see when we get into the GG and J items, and then to increase standardization across post-acute care settings to enable calculations of standardized cross-setting quality measures. Basically, what we're thinking about here is being able to assess the patient in settings across the board, so that it doesn't look really weird how when they come out of a skilled nursing facility, they're ambulating, they look really good, and then all of a sudden we get them in home health and they can't ambulate safely and independently because we're not measuring the same. We're comparing apples to oranges. So what CMS has put in place is an ability to standardize these calculations by standardizing the items and the way that we assess them in all the post-acute care settings. So with the Oasis D, we have new items being added. We have different time point versions on some of the items. Some of the items have been removed. Some of the items have been revised. We have some updated skip patterns, and we see references to coding in items that are not the diagnosis coding items. For example, in the GG and J questions that we'll get to in part 3 and 4, they talk about coding the items, and they're not talking about adding a diagnosis code. They mean filling in your answer as coding. So don't be confused when you see the words coding. They're not talking about diagnosis coding. It's just a new term for answering. Overall, there were 70 items removed from the start of care and resumption of care versions in the Oasis D. There were 18 items removed from the follow-up. There are 42 items removed from the transfer to inpatient facility. There's 1 item removed from the death at home version, and 34 items removed from the discharge from agency. Now, that looks really good at first glance until you realize when they take one of the M questions away or one of the Oasis items away, if the question has 7 possible responses, they count that as 7 items, not 1 question. So we're not getting 70 questions removed, but 70 possible responses. Okay? And that's how this is to be interpreted. Also, Chapter 4 of the Oasis Manual has been retired. That's your illustrative examples. Appendix F is also not included, and the Appendix F used to be where you could go in and find out how to get to your Casper reports and that user manual that you use in order to log in and maneuver your way through. That's no longer in the Oasis D guidance manual. It's now on the QTSO website. So if you're having trouble looking for that Casper reporting manual, you'll need to go to the QTSO website rather than Appendix F because it's no longer there. So now that we know what's changed in the Oasis D, let's look at the criteria for keeping the M items and the GG and the J items in the Oasis D data set. For the items that remain, they have to meet one of the following criteria. They must either calculate a measure finalized for Home Health Quality Reporting Program, or they have to be used in the Home Health Prospective Payment System, or they have to be used in the survey process for Medicare certification, or they have to calculate a measure in home health. If they didn't meet one of those criteria, then they were deleted from the Oasis D. So we have 2 new sections in the Oasis D. Those are sections G, G, and J. I teasingly tell my classes GG does not mean good grief, although it might apply. GG is the section that contains your functional abilities and goals. And then J, it's not jacked up. J is for the health conditions the patient has. And specifically, we're looking at falls with our Oasis D items in the J section that have been added for this year. Now, these sections have been commonly used in other post-acute care settings for many years. For example, in long-term care hospitals, they use a continuity assessment record and evaluation, or a care tool. And so the items might have come from that care tool. Or in skilled nursing facilities, they use a minimum data set, or an MDS. In inpatient rehab facilities, they use a patient assessment instrument, or a PAI. So if you've ever worked with a care tool or an MDS or a PAI instrument, your GG and J items might be familiar when we get around to that. So specifically, the items that have been added, we've got GG0100, prior functioning everyday activities, GG110, which is your prior device use, GG130 is self-care, GG170 is mobility, and that's a very big, long, lengthy question. It takes up 2 to 3 pages in the Oasis if you're looking at a printed paper copy. It's a very extensive question. And then we have J1800 that has us document any falls the patient has had since start of care or resumption of care. And then J1900 is the number of falls if they indeed have had any falls since start of care or resumption of care. Now, I want to go back and revisit why this Oasis D is so important. And certainly we've already talked about the accuracy of the Oasis being important and how all this data is being used. And we've highlighted the changes that are going to be coming in Oasis D. But what I want to remind us are the conditions of participation, or COPs. Now, the COPs have required that each patient receives a patient-specific comprehensive assessment since 1999. Our revised COPs that went into effect January 13th of 2018 updated the standards for content of the comprehensive assessment. And then the Oasis items, we have to be reminded, are a substantial portion of that comprehensive assessment. But remember, the Oasis items themselves, they don't constitute a thorough comprehensive assessment. Remember, your comprehensive assessment includes the Oasis items, your professional head-to-toe assessment, and any agency-specific assessment items, like maybe you do a Braden scale or a tug test, time up and go, and those kinds of things per policy. All of those together is what comprises this comprehensive assessment, but the Oasis itself does not fulfill the requirement for the comprehensive assessment. So all home health patients who receive skilled care are required to have a comprehensive assessment regardless of payer according to the conditions of participation requirements. So in other words, if you're seeing this patient under your Medicare licensed and certified agency, regardless of their payer, if they're receiving skilled care, you have to do an Oasis on them. You may not have to export it, but you would have to do an Oasis with a few exceptions. Okay, and we're going to get into those exceptions in just a little while. So let's look specifically at the COPs that have to do with the Oasis. At 484.45, this is where we find reporting Oasis information. And remember, with the conditions of participation, they're basically telling you if you want to participate in receiving money from Medicare and Medicaid, these are the minimum set of requirements for safety that we are going to have you follow. And the surveyor is the person who actually assesses whether or not you're meeting the COPs. So at 484.45, we're told that the agency must electronically report all Oasis data collected in accordance with 484.55. And at 484.45A, we are told that we must encode and transmit this Oasis data. An agency must encode and electronically transmit each completed Oasis assessment to the CMS system regarding each beneficiary with respect to which information is required to be transmitted within 30 days of completing the assessment of the beneficiary. Now, this became a big deal in the past year or two. We had agencies who were billing final bills, and surprise, surprise, those were getting rejected. And when they went in and looked at the reason why, it was because the Oasis data was not completed and transmitted to the CMS system within this 30-day timeline. So, whatever your M90 date is on your Oasis, M90 is the date the assessment is completed. That date plus 30 days is your deadline. We have to have the Oasis transmitted to CMS by that time, and it has to be on file whenever we send the final bill in. If it's late and it's missing, then your final bill gets rejected and denied. All right, so reporting Oasis requirements, the exceptions to the transmittal requirements. Remember, there's a difference between collecting it versus transmitting. The COPs tell us we have to do a comprehensive assessment on all skilled care patients, but we don't transmit them under certain instances. Now, we don't fill them out either for patients who are under the age of 18, patients who are receiving maternity services, or patients receiving housekeeping or chore services only, patients who are receiving only personal care services until further notice, and patients for whom Medicare and Medicaid insurance is not billed. You would not have to fill out and transmit the Oasis on those patients. Now, if you have patients who are not under 18 and they're not on for maternity services or postpartum services, and they're not getting housekeeping or chore services only, in other words, if you have an adult person who is not pregnant and they are receiving skilled care, you would have to fill out the Oasis, but you might not have to transmit it because you wouldn't be billing Medicare or Medicaid in that case. But anyway, that ties back into your COPs and how you get paid. Now, by the way, with that 30-day timeline to have this transmitted to CMS, as long as your submission time frame is met, in other words, as long as that Oasis gets there within that 30-day period, you're free to develop schedules that best suit your needs as far as how often you transmit. Some agencies choose to do that daily. Some choose weekly. They might do it twice a week. They might do it twice a month. CMS is basically telling you, we don't care how often you transmit this information, but it has to be here within 30 days of the M90 date assessment completed date, and certainly before you file your final bill. Another really big deal about the Oasis and the COPs is found at 484.45b, when we're told here that we must electronically report all the Oasis data collected in accordance with 484.55, and that the accuracy of the encoded Oasis data is a big deal. They tell us the encoded Oasis data must accurately reflect the patient status at the time of the assessment. So clinicians, I want specifically to talk to you right now. While I understand, having been a clinician as well as a manager and a director of nursing and the whole nine yards in my career, an administrator, all of that, I've worked on both sides of that fence. I've been in the field, I've been a case manager, I've been in the office. I've done just about everything in a home health agency that can be done except therapy, and I didn't have a license for that, or I probably would have tried that too. But when we get out there in the day-to-day and we've got a lot going on and we're talking to doctors and we're fighting traffic and we're juggling caregiver schedules and the fact that the patient wants to watch The Price is Right and all this other stuff, sometimes we get so caught up in the schedules that we forget about we've got to take time and make sure this is accurate. Now that the updated and revised COPs have tied this accuracy to the COPs themselves, we see here that if we are going to participate in Medicare and Medicaid money, the encoded Oasis data must accurately reflect the patient status at the time of the assessment. And we're going to learn in the next part of the series how to actually capture this information accurately. What are those true rules and what are the strategies we're going to use to get accurate information? But I just want to stress to you that this is a COP, that this information is accurate. All right, at 484.45c, we see the standards about how we have to transmit the Oasis. I'm not going to get into this as far as detail, but mainly just wanted to let you know the COPs updated this to tell us that for all the completed assessments, we have to transmit that Oasis data according to the QIES ASAP system or whoever that Oasis contractor is, and that any electronic communication software has to comply with the FIPS 140-2 rule, and that we have to make sure we've identified which branch number if we're a multi-branch agency. Now, if you have an electronic health record, normally they are the persons or people or system in charge of making sure that we are compliant with FIPS 140-2. But just to have you know, that is part of the COPs as well, is that we comply with the transmittal regulations. All right, and then the data format we see at 484.45D tells us that we have to transmit and encode the data using the CMS software that's provided to us. Back in the day, this standard used to actually say according to the dial-up system, and of course that's very antiquated. So CMS, when they updated the COPs, changed the language to make it a bit more vague and basically just say whatever we've designated as the latest data format, that's what you need to use, okay? Another place where the Oasis is tied to the conditions of participation is at 484.50A. This has to do with patient rights. And in Part A13, we see that the agency has to provide the patient and the representative, if they have one or they have any, of the following information during the initial visit in advance of furnishing care to the patient. We have to make sure they have the little 2-pager Oasis privacy notice. So again, this is not just the patient. This is the patient and the representative is given a CMS mandated Oasis privacy notice. This is the form usually in your admission packet that is written in English on one side and Spanish on the other, and it basically explains to the patient what an Oasis is, what it's used for, and gives them the right to decline to answer any of the questions on the Oasis if they so choose. So make sure that you not only have those, but you're actually reviewing that with the patient and the representatives if they have any representatives, and that Oasis privacy notice is in the packet in the home, that the patient can reference to it and the surveyor can certainly see it, because again, that's tied to COPs as well. All right, at 484.55A, we see in the COPs the comprehensive assessment of patients, the initial assessment visit here. Each patient must receive and an agency must provide a patient-specific comprehensive assessment on the initial assessment visit. For Medicare beneficiaries, the agency must verify the patient's eligibility for the Medicare home health benefit, including homebound status, both at the time of the initial assessment visit and at the time of the comprehensive assessment. What does that mean? Because that can get a little confusing. For most agencies, we combine the initial assessment and the comprehensive assessment in one visit at start of care or resumption of care. However, not all agencies do that, and CMS gives us the leeway in which to separate those if need be. The initial assessment visit would be the first person who goes out and assesses the patient's needs, and they provide a skilled service, and that would be your start of care date perhaps. The comprehensive assessment would be when you would finish filling out the Oasis items and the rest of the assessment of the patient, and that has to be completed within 5 days of that initial assessment, okay? So, for example, let's say that this is a therapy-only patient, and my home health agency says that therapy-only patients are going to be assessed by the therapist, but we want the RN to fill out the comprehensive assessment for every patient, including therapy-only patients. So in this particular case, the therapist might actually go out and explain to the patient their rights and go over all the admission packet, have them sign the paperwork before any care is rendered, of course, and then they would assess and make sure that they're homebound and they have a face-to-face visit and that we've got a physician who's going to do care plan oversight, and all the criteria are met for this patient to be eligible to receive home health paid for by Medicare. They may go ahead and do their PT eval and provide a skilled service after the patient has agreed to home health services, and then they'll leave. And that would be your start of care date if indeed the patient meets the criteria. Sometime in the next 5 days following that initial assessment, the RN would come in and complete the Oasis and the nursing assessment. And again, according to this, would still go over the patient's eligibility again, because that has to be done, including homebound status, at both the initial assessment visit and the time of the comprehensive assessment. At 48455A1, we see that a registered nurse must conduct an initial assessment visit to determine the immediate care and support needs of the patient, and for Medicare patients to determine eligibility for the Medicare home health benefit, including homebound status. The initial assessment visit must be held either within 48 hours of the referral or within 48 hours of that patient's return home or on the physician-ordered start of care date. Then we see at 48455B1, the comprehensive assessment must be completed in a timely manner consistent with the patient's immediate needs, but no later than 5 calendar days after the start of care. So again, there's a differentiation between CMS and their COPs between the initial assessment and the comprehensive assessment. Most of the time we complete both at the same time, but you can see from the regulations that's not always the case. It doesn't have to be the case, but it does have to be completed timely, this comprehensive assessment, okay? At 48455B2, it tells us that except as provided in paragraph B3 of this section, an RN must complete the comprehensive assessment and for Medicare patients, determine eligibility for the Medicare home health benefit, including homebound status. So what are those exceptions? When PT, speech language pathology, or occupational therapy is the only service ordered by the physician, a PT, SLP, or OT may complete the comprehensive assessment and for Medicare patients determine eligibility for the Medicare home health benefit, including that homebound status. The OT may complete the comprehensive assessment if the need for OT establishes program eligibility. And according to the Social Security Act, the occupational therapist cannot establish program eligibility at start of care. So OT can do a comprehensive assessment at any other timeline, but they cannot perform a start of care assessment, comprehensive assessment. All right, at 484.55C, we see what we have to have in our comprehensive assessment. And again, remember the Oasis is part of the comprehensive assessment, but it's not the be-all, end-all, do-all. It's only part of, but it's never meant to be the comprehensive assessment itself. The comprehensive assessment must accurately reflect the patient status, that's real important to know, and must include at a minimum the following information: the patient's current health, psychosocial, functional, and cognitive status, the patient's strengths, goals, and care preferences, including information that may be used to demonstrate the patient's progress toward the achievement of goals identified by the patient and the measurable outcomes identified by the agency. Now, you may be wondering, why on earth is she going over all of this stuff? I thought I was tuning in for Oasis D. I want to lay the foundation for several reasons. Number one, when we're thinking about the Oasis and the comprehensive assessment of the patient and we're looking at outcomes, the reason that this is important, this comprehensive assessment, the comprehensive assessment is basically the foundation on which you're going to build this care plan. It's the foundation on which you're going to figure out what the patient's needs are and what the patient's goals are. So, of course, it makes sense that you want to know what their current health status is, whether or not they have the psychosocial elements that they need. Do they have a good support system in place? Are they able to afford their medications? Because if they're breaking them in half, they can't afford the whole prescription every month, so they're breaking the cardiac drug in half to make it last over 2 months, and they keep having exacerbations. That's going to impact both the care that I deliver and the patient's outcomes. And then their functional status, we want to make sure we can show a good outcome. So we want to make sure that functional status is captured accurately at the beginning so that by the end we can show some improvement if they have them. And then their cognitive status, that's going to impact what your plan of care will be as well. So it just makes sense then that you do a thorough comprehensive assessment and that this is part of that CMS required assessment. Then we also look at their strengths and goals and care preferences, because we know that if we take some time to really identify what this patient has going for them, they have good financial situation, they have great daughters and sons who are participating in their care and are very supportive, and you can call them up and say, you know, your mom needs this, and they get out there and they get it done. That makes a huge impact on this patient's outcomes. And then what's the patient's goals? If you can help them identify one thing that they want to get out of this home health care episode, then you've got some buy-in there. If they are just kind of humoring you and letting you come and they don't really know or care why you're there, then you're probably not going to get a patient engagement level that is going to be needed to have some good outcomes. So all of that together in the comprehensive assessment then is documented and translates into that patient's plan of care, and all of that helps us to demonstrate the patient's progress toward the achievement of the goals that are identified by the patient and the measurable outcomes identified by the agency. So all of that to say the assessment ties into the Oasis not only because of the COPs, but also we've got to have that foundation as far as what is our roadmap, where do we want to go, how are we going to get there, and also because the Oasis instrument itself is geared for outcomes assessment, we've got to be able to compare and show those outcomes throughout our documentation. All right, we also see that the comprehensive assessment must include the patient's continuing need for home care, the patient's medical, nursing, rehabilitative, social, and discharge planning needs, and then a review of all the medications the patient is currently using in order to identify any potential adverse effects and drug reactions, including ineffective drug therapy, significant side effects, significant drug interactions, duplicate drug therapy, and noncompliance with drug therapy. And again, we know there are items that actually ask us if we've done a drug review or if the patient's had any significant side effects and so on. We also see the comprehensive assessment must include the patient's primary caregiver or caregivers, if they have any, and other available supports, including those caregiver or support persons' willingness and ability to provide care and their availability and schedules. So if you didn't already know that, we are supposed to be finding out the availability and schedules of these caregivers. And then also we have to know who the patient's representatives are if they have any. Lastly, we see that incorporation of the current version of the Oasis items and using the language and groupings of the Oasis items as specified by the Secretary, and the Oasis data items determined by the Secretary must include the following. It must include the clinical record items, the demographics and the patient's history, the living arrangements for the patient, the supportive assistant status, the sensory status, integumentary status, respiratory status, elimination status, neuro, emotional, and behavioral status, their activities of daily living, the medications, the equipment management, emergent care, and then data items that are collected at inpatient facility admission or discharge only. So again, all of that just to say, remember your agency items, the Oasis items, and then discipline-specific items are what makes up this comprehensive assessment. And we're going to focus in the rest of our series on the Oasis items, but I wanted to lay that foundation to help us remember why the Oasis is so important and that Oasis accuracy is part of that, and it's actually tied to our conditions of participation. The comprehensive assessment of patients must be updated and revised, including the administration of the Oasis, as frequently as the patient's condition warrants due to a major decline or improvement in the patient's health status, but not less frequently than the last 5 days of every 60 days, beginning with the start of care date, unless there's a beneficiary elected transfer, a significant change in condition, or a discharge and return to the same agency during a 60-day episode. Now remember that significant change in condition, that's a significant increase or decrease in their condition that was unexpected. And we kind of got away from doing SCICs as an industry when they no longer adjusted payment midstream like they did early in the early 2000s. But you should still be filling out follow-up Oasis or doing the follow-up Oasis when there is a significant change in condition. The patient got a lot better than expected, or they got a lot worse than expected, and you didn't see it coming when you were looking at your original plan of care and your first comprehensive assessment. We see here that we are to update the comprehensive assessment when that happens. When we're talking about updating that comprehensive assessment, we also have to realize that that update has to be done within 48 hours of the patient's return to the home from a hospital admission of 24 hours or more for any reason other than diagnostic test or on a physician-ordered resumption of care date, and of course at discharge. So now that we've reviewed the history of the Oasis and what the Oasis is trying to accomplish, why it's so important, we've tied in the elements of the Oasis that are connected with the conditions of participation, and we've also talked about the timelines as far as how often that comprehensive assessment of patients has to be done. We're going to conclude session 1 at this time. Next in our webinar series, we're going to learn the official CMS guidelines and rules for filling out the Oasis D dataset. And that's a real important webinar to attend as well. And in the meantime, if you have any questions, you're welcome to contact me. My name has changed. I'm recently married. Jennifer Gibson Osborne is my new name, but I'm the same old Jennifer Gibson you've been listening to for 5-6 years now. You can reach me still at jgibson@axxess.com, and you are welcome to call or text me on my cell number, which is 972-975-0417. Okay, thank you very much for joining us, and we hope to see you again soon for part 2 of our Oasis D Accuracy webinar series. Thank you again, and have a great day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.